Unmute.
Dr. Jose.
Yes, Josh, please speak.
I'm Dr. Jose Babu from Alpha Palliative Care, Thrissur.
Okay, thank you.
Welcome, sir.
Thank you.
Dr. Libika. Dr. Libika, please introduce. Dr. Libika.
No, they are not accepting you. Mute yourself. Wait there.
Dr. Babita. Dr. Babita, please introduce yourself.
Hi, can you hear me?
Hi, yeah, we can hear you.
Hi, I'm Dr. Babita. I'm from Karnashraya, Bangalore Hospice Trust.
Okay,
Nice to be here. Thank you for giving this opportunity.
Okay. I think we can go next to Dr. Anne.
I will introduce Dr. Ann because she is one of the faculty who has agreed us to join for one of the sessions on Methadone. Dr. Ann is previous director of education at Iowa University, and she's a professor of palliative medicine, and she also works with Pallium India and is helping in many ways. Thanks, Ann.
Thank you. Very generous. Do we have, is Kashelle on the line yet?
No.
Okay. I'll just,
Yeah. The session starts at 7:59.
okay, I have to translate that to Iowa.
Yeah.
In about 15 minutes, is that right?
Yeah. 8 minutes. Yeah. Biji, please unmute and introduce yourself. Biji, unmute. Yes,
Can you hear me?
Yes, please.
Can you get me some I am Dr. Biji from Malabar Cancer Center, Talsheri, from Kerala.
Welcome, ma'am.
Nice meeting you all.
Dr. Libika, can you hear us? Dr. Libika.
May I say something, if it's all right? This is Dr. I think she's been calling me. She's not able to hear anything what anybody is saying.
Okay. Okay, sir, Dr. Jean Jacob, sir, please introduce yourself.
Yeah, hi. Am I audible?
Yes, sir. Yes.
Yeah. So I'm Dr. Jean Jacob. I'm from MNJ Hospital and Pain Relief and Palliative Care Society, Hyderabad. Currently, I'm logging in from Minneapolis. Thank you.
Thank you, sir. Welcome. Anu? Please, Anu. Please introduce Anu.
Time, can you hear me?
Yes, we can.
I am facing some.
Anu?
Anu, please. I think I have facing some technical problem. Can you see?
We can hear you. We can hear you.
Okay, I am Anu. I am from Pondicherry. I am working as a nurse in Mahatma Gandhi Medical College in Research Center.
Welcome, Anu. Dr. Reza.
Hi, can you hear me?
Yes, sir. Yes, we can hear you.
Yeah, I'm Dr. Rajat. I'm a palliative care and a family physician based in Coimbatore. I'm based in a tertiary care center, GKM Hospital.
Welcome, sir.
Hi, sir. Thank you.
Dr. Jayarajan. Sir, please.
Good evening, everybody. Am I audible?
Yes, sir. Yes.
Yeah, I'm Jayarajan. I'm basically from Kerala. I'm representing Palcare Jimmy S. Bilimoria Foundation. I'm its Chief Medical Officer.
Okay, welcome, sir. Welcome to Taste Report.
Thank you. Thank you.
Dr. Akhil. Dr. Akhil. Okay. Dr. Tracy Smith.
Echo in New Mexico, just observing.
We couldn't hear you. Can you please?
Can you hear me?
Okay, okay. Now we can hear you.
Hi, I'm Tracy Smith. I'm with Echo in New Mexico, just observing today.
Okay. Welcome, ma'am.
Thank you.
Dr. Spandana. Dr. Spandana, can you hear us? Dr. Spandana, can you hear us? No. Dr. Gayatri, can you hear us?
Yeah, I can hear you very well.
Ma'am, can you please introduce, ma'am?
Yeah, I'm Dr. Gayatri Palat. I'm from Hyderabad, working in MNJ Cancer Hospital. I'm giving you to all of you.
Welcome, ma'am. Welcome to Taste Report. Dr. Sitara. Dr. Sitara. Dr. Alte. Alte, can you hear us?
Oh, that's cool.
Hello, can you guys hear me?
Yes, Dr. Kashelle, we can hear you.
Hi.
Hi.
So good to see you.
Hi, Sumita. Can you hear me?
Yes, we can hear you, Alte. Alte, please introduce yourself.
Hi, Sumita. I just got back from work. I'm having my food right now, so
Yeah, we could
I think I'll get back in like.
Okay.
So I'll just quickly eat my dinner and come back to you in like 2-3 minutes.
Okay.
Yeah. Okay. Thank you.
Dr. Spandana. Dr. Spandana, can you hear us?
Yeah, I can hear you very clearly.
Okay.
Thank you.
Please introduce yourself.
Hi, I'm Dr. Spandana. I have joined recently the Pediatric Palliative Care Fellowship at MNJ. I'm 2 months into the fellowship and I'm working at MNJ RCC with Dr. Gayatri Palat.
Oh, welcome to this. Dr. Sunita.
Thank you.
Dr. Sunita.
Hello, hi.
Hi.
Sorry, I was late.
Please, please introduce yourself. Ma'am, please introduce.
Hello.
Hi, ma'am. Ma'am, can you hear us? Dr.
Yeah, I can hear you.
Awesome. Please introduce, ma'am.
I'm Dr. Sunita Daniel. I'm working in Amrita Hospital.
Welcome, ma'am. Welcome. Dr. Anil. Dr. Daniel, sir? Dr. Daniel?
Hello.
Hello, sir. Are we audible?
Hello.
Hello, sir. Can you hear us?
Am I I can't hear you. It's breaking, but am I audible there?
Yes, sir.
Can you hear me?
Yes, sir. Yes. Sir, please give a brief introduction, sir, about yourself.
Yeah, I'll do, but I'm a bit technically challenged here. I'm traveling. It's an unexpected thing, so I'm just trying to connect from my hometown, and the connection is a bit slow here. It's a bit challenging, but I'll try. Nevertheless, try to join the program. So don't worry if I kind of switch off and switch on in between. So that's likely to happen. That's what I'm thinking. Anyway, I'm Dr. Anil Paleri from Calicut in Kerala, and I was with IPM earlier. Now with the local palliative care program. Thank you.
Welcome, sir. Welcome.
Please be quiet. I'm going to record.
You have to leave and join it again.
Hi, I just wanted to confirm, are you going to show my slides from there, or do you need me to share my screen?
Oh.
Dr. Kashelle, will show your slides from here.
Join it.
You'll show from there? Okay.
Are you able to hear? Are you able to hear now? Okay, okay. You just have to leave the video and rejoin it again. Okay, okay. Then he'll do correction. Let me know. Okay.
Dr. Divagaran, sir, please introduce yourself, sir.
Yes, I'm listening.
Sir,
I'm hearing.
Sir, please introduce yourself, sir.
I'm Dr. Divagaran. I'm working as the Director of Institute of Palliative Care, Thrissur.
Okay, welcome, sir. Welcome.
Pardon?
Welcome, sir.
Welcome. Thank you.
Dr. Vidya. Dr. Vidya Vishwanath. Dr. Vidya Vishwanath, are you audible?
I think someone has to mute their mic because, excuse me.
Okay.
Because there are voices of kids that are audible, right?
Yes, yes.
Is it from your center?
No.
Okay.
I think those are not speaking, please mute yourself. Dr. Vidya, can you hear us? Dr. Vidya? Dr. Vidya, can you hear us? Hello, yes, I can hear you. Okay, ma'am, please introduce yourself, ma'am.
Dr. Vidya Vishwanath, I can hear.
Ralph? Dr. Ralph?
Hey, I'm back. Yep.
Please introduce yourself, Ralph.
Yes. Hi, everyone. I'm Dr. Ralph from Aizawl, Mizoram. Recently attended the training for doctors.
We couldn't hear you properly.
അങ്ങനെ കംപ്ലീറ്റ് ആണ്.
Healthy?
Yeah.
Please introduce yourself.
Again.
We couldn't hear you.
All right. Okay. Again, my name is Dr. Alte from Aizo, Mizoram. That's in the northeast part of
Mute your computer.
Dr. Shamla.
Hi.
Hi. Can you introduce yourself?
I'm Dr. Shamla from Kashelle Palliative Institute.
Okay. Okay. Welcome, ma'am. Welcome.
Thank you.
Dr. Naveen. Sir. Sir, can you hear us? Sir, please introduce yourself, sir. Sir, please unmute, sir.
Yeah, sure. Hello everyone. I'm Dr. Naveen Silence. I work as a palliative care physician at
Microphone Your microphone has to be muted. I mean, when you are not speaking, background noise is coming over.
Okay.
I mean, unmute only when you are speaking. Ah, yes, that's fine. Thank you. What happened? Have we lost everybody? Sumita? Sumita, you are muted now.
Okay. Good evening to all. We welcome you all to the 5th ECHO session in season 2. And today our faculty is Dr. Kashelle Lockman. Dr. Sunil, who is our additional director, will give you a brief introduction about Dr. Kashelle.
It's good morning to Kashelle and good evening to all. Dr. Kashelle Lockman is a clinical assistant professor at Hospice and Palliative Care at the University of Iowa College and clinical pharmacy specialist in the outpatient palliative care clinic at the University of Iowa Hospitals and Clinics. She serves as a faculty for UHC Hospice and Palliative Medicine Fellowship Program. She creates and teaches palliative care content across the Doctor of Pharmacy curriculum, in addition to teaching in the University of Iowa India Wintering Course with Dr. Anne Broderick and Pallium India. Her research interests include pharmacopalliation, opioid safety, and evaluation of instructional methods. I welcome Kashelle Lockman for this session, and we will start sharing the screen from here. So, welcome you.
Thank you very much. It's a pleasure to be here with you this morning. Thank you, or evening there. Thank you for inviting me. I look forward to talking with you all about methadone. It is an exciting medication. So I'll just wait for my slides to get up and we'll get started. Okay, so this evening we're going to talk about why it's important to know the pharmacology of methadone. And my able to move the slides from here, or do you guys need to move? Okay. So the objectives by the end of this session, I hope that you all will be able to describe the impact of methadone's mechanism of action on drug therapy decisions, explain interpatient variability in methadone responsiveness, contrast methadone's side effects with those of other opioids, and explain how the pharmacokinetics of methadone impact dosing considerations. Next slide. So first, I want to just describe a couple of terms. Pharmaco, if you could hit next. Pharmacokinetics are what the body does to drugs that we take. And then pharmacodynamics are what the drug does to the body. And then layered on top of that, we have pharmacogenetics. And these are genetic differences amongst us that may change the way we handle a drug or the way our body reacts to a medication. Next. So methadone is very unique in terms of its pharmacodynamics. It comes as a racemic mixture in most countries of S-methadone and the enantiomer R-methadone. Now, like other opioid medications, it agonizes the mu-opioid receptor and also agonizes delta and kappa opioid receptors. R-methadone is about 8 to 50 times more potent than S-methadone at this receptor. Both enantiomers or isomers antagonize NMDA. Now, NMDA is a receptor that's in the dorsal horn, and we know that its activation is involved in upregulating our body's responsiveness to pain. So it amplifies and generates a chronic pain state. And by antagonizing this receptor, methadone can really help prevent tolerance to medications and help prevent development of some neuropathic pain. So methadone also can inhibit the reuptake of serotonin and norepinephrine. And this is thought to be mostly due to the S isomer of methadone. So this is something we'll talk a little bit more about. In addition to these therapeutic benefits of methadone, the S isomer of methadone acts at the human ergogogo channel. And this is a potassium channel in the heart that has a crucial role in how our heart's rhythm is generated. So that can be important from a toxicity level. Next slide. So let's talk about the clinical impact of this drug's action at these receptors. Mu receptor agonism, we can expect from methadone the same side effects that we see from other opioids. So we can have respiratory depression, which is usually preceded by sedation. Also, it can cause constipation, nausea, urinary retention, itching, and sometimes we see edema, not as commonly. These side effects are dose dependent. And then, of course, we also have the benefit of the analgesic effect in addition to those side effects. So thinking about NMDA antagonism, this is from a study that was done in the United States. And I've taken 4 patients from this study and shown you the wide variety of doses of morphine we can see different patients needing. So patient D needed about 1,200 milligrams of oral morphine equivalents a day, whereas patient A was getting almost 10 times that much morphine a day. All of these patients had poorly controlled pain on morphine, and so in the study they switched them to methadone. Now, those of you who are joining us, I want you to think about how much methadone you would think patient A needs versus patient D. Let's see. And now let's go to the next slide. And in fact, in this study, they found that all of these patients were comfortably controlled on the same dose of methadone. So they started methadone at various doses, and then they titrated the dose slowly over time to the patient's pain comfort goals. And all of these patients needed methadone 10 milligrams every 8 hours at the end of this process. So here we can see that when we're giving more and more doses of opioids, Sometimes our body actually gets pro-analgesic, and so pro-nociceptive, and so more opioids can generate more pain sometimes when we get to these high doses. And this is called opioid-induced hyperalgesia, but it also can be called tolerance. And so this exists on a spectrum. We know that methadone can reduce this kind of tolerance that we see, and that's what explains the reason why patients on very high doses of morphine, very high doses of morphine often need lower doses of methadone than you might expect. Next slide. So NMDA antagonism, as we saw from this study, prevents and reverses tolerance. And in this study, it reversed tolerance for those patients. And it also can have an added analgesic effect and help with neuropathic pain. As a general rule, the higher the patient's dose of morphine needs, the lower the dose of methadone you will need. So it's not a linear relationship. For this reason, we start low and go slow based on this pharmacologic parameter of methadone. Next slide. Because methadone inhibits a reuptake of serotonin, we can also get an additional analgesic effect from the norepinephrine reuptake inhibition. That is part of the reason why methadone may be more efficacious for neuropathic pain than other opioids. But it also comes with the problem of having more drug interactions, because methadone will interact with other serotonergic medications and increase the risk of a patient developing serotonin syndrome. So when we're going to start methadone on someone, we need to think about the serotonergic potency of other medications that they might be on. These include tricyclic antidepressants, SSRIs, and SNRIs. And MAOI inhibitors are so potent that I would not use them with methadone at all. But in general, in practice, when we're starting methadone on someone who's taking SSRIs or SNRIs, I try to make sure that they're on a low serotonergic potency medication if I can. And sometimes we don't have a choice because a patient has been on a medication for a long time and they've failed other medicines. And so maybe, for example, citalopram is what really helps a patient's depression, and we don't want to, or we cannot rotate them to another SSRI. In that case, next slide, we monitor and make sure that the patient doesn't develop serotonin syndrome. Now, serotonin syndrome is incredibly rare at the serious levels, being coma, respiratory failure, myoclonus, and seizures. But we do, it does exist on a spectrum, as you can see here, with milder forms, including insomnia, tremor, agitation, and restlessness. So if you start methadone on someone and they are on a lot of other serotonergic medications, and you see the patient becoming more agitated, if they develop a temperature of greater than 38 degrees, that's sort of a hallmark sign of serotonin syndrome, and you want to intervene early rather than later so that it doesn't develop into a severe syndrome. Next slide. Now, I mentioned that S-methadone can activate the human ergogogo potassium channel. This can lead to QT prolongation. And so we're always worried about a patient's risk for QT prolongation when we're thinking about methadone, and we don't use methadone if a patient has a family history of sudden cardiac death. Or if their QTC interval is more than 500 milliseconds, we try to use other analgesic medications. If they have a congenital long QT syndrome, we wouldn't want to use methadone. For other patients, we try to minimize risk factors that are modifiable for QT elevation, and we're pretty good at this. A study at MD Anderson in the United States showed that in palliative care patients, there was only clinically significant QT prolongation in 1 out of 64 palliative care patients started on methadone at an outpatient palliative care clinic, and there was no torsades or sudden cardiac death. Other studies have shown in pain and palliative care patients, risk factors for QT prolongation can include an elevated QT interval at baseline, methadone total daily dose greater than 45 milligrams, heart failure, low blood potassium, malignancy, low blood calcium, peptic ulcer disease, and rheumatologic disease. This was an interesting risk factor that shook out to me, and I think it's likely because patients taking with these illnesses may have been on proton pump inhibitors, which we know can cause low magnesium, but the study didn't dig into why peptic ulcer disease and rheumatologic disease were risk factors. That's just a theory based on what I know about what those patients are usually taking in terms of meds. And then if patients are taking other medicines that have a known risk of torsades or other medications that increase methadone levels, those are also risk factors that have been shown in studies in palliative care patients. Next slide. So this is a tool that was developed for inpatients, so patients who were being treated in hospitals, to look at their risk for QT prolongation. And it may be a useful tool to think about using as you start using methadone. I would say that you're not always going to have all this information, but you can check off the boxes for the information you know. You may not always have an EKG, but if you know a patient just had a myocardial infarction, for example, you could give them 2 points. You could add up the risk factors that you are aware of and see if they're low, moderate, or high risk. This is just to sort of help you put some of these risk factors into context. So a patient could be just on one QTC interval prolonging medication and not have any other risk factors, and they would still be low risk for developing QT prolongation. Now, if we were adding methadone to one of those patients, that would make their score 6. And they would still be low risk, even if they were on 2 of the QT prolonging medications. Next slide. Here's a list of drugs that have known risk of torsades for your reference. This is available for free online at crediblemeds.org. You have to sign up, but you can get a free account and have access to their database. There are lists, but if you search by drug, it will give you more information about the data behind that drug's ranking as known risk, conditional risk. And so these are sort of the ones to keep on your radar. Oh, I see there's some questions on the chat box. What's HERG? Yes, HERG is a subunit of a potassium channel in the heart that is important for developing heart rhythms and maintaining normal heart rhythms. And so, all right, so drugs with conditional risk are listed here as well. Again, here you see the proton pump inhibitors are on this list, which are commonly used in palliative care populations. Next slide. So another aspect of pharmacodynamics of methadone that make it unique is that if a patient had a true opioid allergy to morphine, which is very rare, you could use methadone for that patient's pain, and it would be a very low risk of cross-allergenicity to methadone. Next slide. So now let's shift into talking about what our body does to methadone, pharmacokinetics. Whenever we think about pharmacokinetics, we think about absorption, metabolism, distribution, and excretion. Next slide. So methadone has high oral bioavailability of 80%. It ranges from 36 to 100%. And it even has sublingual absorption. So it will be absorbed across the oral mucosa about 30%. And this is better absorption across the oral mucosa than morphine, which is only about 18%. And this is because methadone is far more lipophilic than morphine. Next slide. When we think about distribution of methadone, it's pretty unique. If you administer a dose, because it is so lipophilic, it will initially want to go into tissues such as brain, gut, kidney, liver, muscle, and lung, and it will distribute there preferentially. Very little methadone will be available in the free fraction in the plasma. And methadone would have to be available in the bloodstream as free, unbound methadone in order to interact with the receptors that provide analgesia. 81 to 97% of methadone is actually bound in the blood when it is out of the tissue to alpha-1 acid glycoprotein. And this can vary about fourfold amongst individuals. So this is one of the variables in methadone responsiveness. Now, you have that initial alpha phase distributing into the tissues, and then the drug elimination or slow beta phase will begin. And the half-life varies on the elimination from 8 to 60 hours. Some reports in older patients have even shown terminal half-lives of up to 120 hours. If you could hit next. So the average half-life elimination is 22 hours. Next. So as the administered dose saturates tissue binding sites, you again will only have the benefit of analgesia and the harms of side effects from the free methadone in the bloodstream. Next. And this is showing you steady state. So the tissue binding sites are saturated, and there's a dynamic equilibrium between the tissue binding sites and what's freely available in the bloodstream. And this shaded gray box here is just to indicate that all that methadone may be in the bloodstream, but again, only a small amount of it will be free and not bound to alpha-1 acid glycoprotein. And only the free methadone is available to interact with receptors. Can you hit next? So it takes 5 half-lives to get to steady state, just like with all other drugs. Because the average terminal half-life of methadone is 22 hours, that means it's going to take 5 to 7 days before you'll see the impact of a dose change of methadone. Next. So once you're at steady state, the analgesic effect of methadone will last 8 to 12 hours. Contrast this to morphine, which we know only lasts 3 to 4 hours. Here's a sample picture of pain for a patient who has persistent, around-the-clock, severe cancer pain, and they're taking morphine every 3 hours, as you can see on the x-axis there. As the morphine wears off, their pain is spiking up to a 10, and then it's coming back down when they take their next dose of morphine. This really creates a pain that's hard to control for patients. They're watching the clock. They know their pain is going to get incredibly severe and excruciating again as that morphine wears off. So can we do something better? Next slide, please. Because methadone's drug properties and that a dose at steady state will last 8 to 12 hours, it provides sustained analgesia for patients. So here we have the same patient who we started on methadone, and now once they're at steady state, you can see that they're not having these spikes of pain up to 10 as often. The methadone is bringing their overall level of pain down. And for times when they do have their pain spike up to a 10, we can give them short-acting morphine to control that extra pain. And here, this is pretty typical of what we see when we start patients on methadone. They need far less doses of the short-acting opioids, but they still will need some usually. Next slide. When you stop methadone, it does take a while to clear it from the body because the free fraction will be maintained until all those tissue binding sites are exhausted. And so you've accumulated methadone in your tissues, and now your body has to slowly release it and get rid of it. Next slide. And continue next. This is just showing you the free fraction leaves, and then your tissue binding sites will be exhausted. This is another way to look at the road to steady state with methadone. And here I want to once again say it takes 5 to 7 days to see the full impact of a dose of methadone. And in some older patients with advanced illness, it can take even longer. Here's 2 different patients. The solid line is a patient who has a 25-hour half-life of methadone, and the dotted line is a patient who has a terminal half-life of 50 hours. You can see after 48 hours here, we're not at steady state. At 72 hours, we're still not at steady state. So if we increase the dose 3 days after starting methadone, we run the risk of dose stacking, which could increase the risk of side effects and harm. Typically, we'll only increase the dose of methadone this soon if a patient is on a monitored hospital unit where we can closely see how they're responding to the medication and respond to changes. If a patient is at home, again, we wait usually 5 to 7 days before we would increase the dose. Now, why would one patient have a 25-hour half-life and another have a 50-hour half-life? Next slide, please. Next slide. Okay, next slide. All right, so one reason could be that the patient has liver disease. And this can particularly be problematic with cirrhosis and combined with biliary obstruction. Next slide. This is because, go back one more. This is because methadone is extensively metabolized in the liver by most of the CYP enzymes that we have in our liver. If you compare this to morphine, you can see that it's only glucuronidated by a phase 2 enzyme. And we know that morphine is primarily cleared through the kidneys and has active metabolites that can accumulate in renal failure. Methadone doesn't have this problem, but we do have to be careful in liver disease. And I also want to point out that those of you who've heard about methadone before may have always heard about CYP3A4 being very important for methadone metabolism. And more data from a researcher at Washington University has shown that CYP2B6 is one of the most important enzymes to metabolize methadone. Next slide. All right, because methadone is so extensively broken down by our liver enzymes, we have to worry about a lot of drug interactions that can impact the activity of these liver enzymes. And so this slide is specific for methadone. So some of the common drugs that induce methadone, if you just want to have a sort of easy way to remember it in pharmacy school here, we teach the students PS ports. And so phenytoin, smoking, phenobarbital, oxcarbazepine, rifampin, and ritonavir, carbamazepine, and St. John's wort all induce methadone metabolism. Now, ritonavir is normally an inhibitor. It is a strong inhibitor of CYP3A4, but research has shown that for patients on methadone, ritonavir's more of an inducer, and this is because it induces CYP2B6. So if a patient is on ritonavir, you can expect methadone to be more broken down than in patients who aren't on ritonavir. And this is different than most other medications that interact with ritonavir. Inhibitors of methadone metabolism and breakdown include grapefruit protease inhibitors aside from ritonavir, azole antifungals like fluconazole, antidepressants, cimetidine, macrolide antibiotics, amiodarone, and non-dihydropyridine calcium channel blockers like verapamil and diltiazem. And the way to remember these easily is GPAC-man. So induction can take 1 to 2 weeks to occur, although we do see some induction of methadone metabolism in single dose studies with ritonavir as well. But typically you won't see the full effect for a couple of weeks. Inhibitors, on the other hand, inhibit methadone's breakdown right away. Next slide. So how does this impact our drug selection and using methadone? We need to make sure we know all the medicines that a patient is taking so that we know what to monitor for in terms of how methadone will work in their body. And so this is important to ask about Ayurvedic medications and allopathic medications. There isn't much data on Ayurvedic medications and methadone. I didn't find any Ayurvedics that are currently known to impact the activity of CYP2B6, one of methadone's most important metabolizing enzymes, but we just haven't studied it. So I think it's important to record it and see how patients do, and that would be important knowledge to develop and share. We want to educate patients and their caregivers to let us know about any new medications they start and to let other prescribers know that they take methadone for pain. And then when we can, if there's a serious drug interaction like a strong CYP inhibitor like fluconazole, for example, we want to switch to alternative medications for antibiotics and things like that when we can, and antifungals. Next slide. So this is just to show you the impact of an inducer. So an inducer can increase the activity of the enzyme. Can you click next? And then it can also, click next again, it can also increase the levels of that enzyme in our body. And that's what takes more time because genes have to be upregulated and proteins have to be made. So this will decrease the effect of methadone as an analgesic. So what do? We just monitor because we don't know how the patient will respond exactly. We don't have good dosing guidelines for this. And we'll use short-acting morphine for any extra pain they have when we start an inducer. If we stop an inducer, they may actually get more sedated from their methadone. So we'll reduce the dose by about 25% if it's a strong inducer and we're stopping it. And then we monitor closely. Next slide. Inhibitors inhibit the activity of the enzyme right away. So the net effect would be increased levels of methadone in our body and decreased inactive metabolites of methadone. Next slide. So if we're starting a strong inhibitor, we would reduce the dose of methadone by about 25%. And there's not good data for that, frankly. So we're just conservative and we monitor the patient carefully. This is a list of enzyme inducers. And there's a website that you can access that's freely available online from Illinois University that I've linked here. It has a good list of medicines that increase enzyme activity or decrease enzyme activity of enzymes that break down methadone. Next slide. And here's a list of the inhibitors. Again, you want to pay particular attention to the 2B6 inhibitors and inducers. Next slide. So, as I mentioned in the beginning of the presentation, pharmacogenetics adds another layer of diversity in how we respond as individuals to medications. And this is a recent, some recent findings on how different populations express different drug metabolizing enzymes. So if we look at CYP2B6, which is one of the most important ones for methadone, the SAS is a South Asian population, and AMR our mixed American population. We can see that 16.7% of the South Asian population had decreased activity of this drug metabolizing enzyme versus 4.4% of a mixed American population. 2C19 is another enzyme that metabolizes methadone. We can see that 34% of the South Asian population versus 10.7% of the American population had decreased activity of the CYP2C19 enzyme. And then for CYP2D6, 35% of the South Asian population versus 25.3% of the American population had decreased activity of CYP2D6. So what this means is that we have a lot of experience dosing methadone in America, but that doesn't mean that what works here will necessarily work for all patients that you're seeing. And we're still learning more and more about our genetic variability and how our bodies respond to medications. And so I think the key here is to be conservative with your dosing, collect what happens, and share your knowledge with each other. Next slide. There's a couple of small studies that indicate that actually that this may be a little bit more complicated in India. So there were these small studies limit generalizability, and we need more data, but in patients who are ancestral North Indians, they had poor metabolizing phenotypes of CYP2B6 about 21% of the time versus ancestral South Indians who had that 28% of the time. However, the allelic frequency was much higher, 44%. So patients who are heterozygous for this allele, so they have one copy of a fast metabolizing enzyme and one copy of a poor metabolizing enzyme, managed to metabolize the drug just fine. But those who had two copies of the poor metabolizing enzyme had increased levels, and this study was with efavirenz. So we don't have any studies specifically with methadone. And again, these were small. Next slide. So in summary, methadone analgesia and toxicity is determined by pharmacogenetics, and this could be in the drug metabolizing enzyme, and something we also didn't touch on yet is that it could be in the receptors and how our body responds to the medications. They could be slightly different amongst different individuals. And then drug interactions can impact methadone's effect, as well as the levels of alpha-1 acid glycoprotein. So we know in cancer that alpha-1 acid glycoprotein levels are increased. It's an acute phase reactant. We don't think that it has a huge clinical impact on methadone, but it's important to keep that in mind in case you had a patient who was responding well and then all of a sudden their response changed. See if they have an infection or cancer or something like that that could cause acute phase reactants. And then patient-specific factors. Patients who have heart disease are more subject to harm from methadone. Patients who have severe lung disease may be more subjected to respiratory depression. And then liver disease, they may have increased levels and need lower doses of methadone. Next slide, or click next. So the key here is to start low and go slow. Wait 5 to 7 days to see the impact of a dose. To use morphine for breakthrough pain, and to collect data and share your experiences. And so now I'd like to open it up to any questions. I see there's a couple in the chat. Okay.
Hi, can I ask a question?
Yes.
I had a question regarding methadone for breakthrough pain. In your slide, you had mentioned that you use morphine for breakthrough pain. Can we use methadone also at 1/10 the dose?
I do not do that because you run the risk of accumulation. The only time that I would use methadone for breakthrough pain is a true morphine allergy, which I have not seen. And my colleagues who have been around much longer than me usually only seen 1 to 2 at a lifetime. So it's much safer to use morphine for breakthrough pain. Because again, the methadone, even though the analgesic effect has gone, it stays in the body, and you're running the risk of it causing toxicity.
Hello?
Yes.
There's a problem with the audio. I don't know.
Yeah, it's echoing a lot. We're unable to hear. I don't know if everybody is facing the echoing problem.
Is it still echoing?
Not clear. We're not able to. All this time, audio is great.
Dr. Kashelle?
Yes.
Yes, sir, now we can hear you.
You can hear me now?
Yes.
Yes.
Okay. So
If you could repeat the first question and answer this one.
The first question was, can we use methadone for breakthrough pain? I would not use methadone for breakthrough pain. Again, it has a very long half-life, so its pharmacologic properties do not make it a good choice for breakthrough pain. You want to use a medication that acts rapidly and is rapidly cleared from the body for breakthrough pain. So unless a patient is allergic to morphine, which is very rare, and we had no other option, I would not use methadone for breakthrough. And in fact, I've not seen that, and my colleagues who've been around in palliative care for decades have only seen it once or twice in their lifetime. So as a rule, no methadone for breakthrough pain. Oh, no, I did not make a recommendation. I see a chat question that I made a recommendation to start methadone at 5 milligrams every 6 hours, whatever the dose of morphine. No, I did not make a dosing recommendation. There's another echo session on methadone dosing that needs a whole session. Dose will be the next class. The dose will be very low. That would be high, and so I think we need to talk about that next time. It's going to depend if the patient has already been on opioid medications or not, and also their age and other characteristics. Okay?
There is also a question about missing a few slides. I think Dr. BG has asked, but please be assured that we'll be sharing these presentations to everyone, at the end of this session. So you can go through the slides anytime, any other time. Are there more questions?
Hi, I'm Dr. Mandya. Hi. I see that there's probably drug interactions. So before we start Methadone, we stop the drugs that the patient is taking for interacting with Methadone.
So I think the question was, do you stop drugs that interact with methadone before you start methadone? Yes. That is certainly the easiest thing to do. If you can, you want to minimize as many drug interactions as possible. Sometimes our patients still need medications that interact with methadone, and we have to look at the severity of the drug interaction as well. So that's a good time to consult with pharmacists, if you have a pharmacist there, to evaluate each individual patient's medication. The best thing is to stop an interacting medicine if you can. If you can't, then you would develop a monitoring plan. And sometimes we would start with a lower dose of methadone, for example, to be conservative, and make sure they had some morphine to use for extra pain while we work on getting the dose right. There's also a question in the chat box about any age barriers to the use of methadone, especially the elderly. So the elderly usually need much lower doses of methadone, but they can use methadone safely. I've used methadone in patients as old as 90. Sometimes they only need it once a day when they're older, like 90. So very low dose. I've even used as low as 1 milligram at bedtime in very elderly patients, and they've gotten good pain benefit from that. And then I see, is methadone available only orally or also other routes? So if someone from Pallium could weigh in, it is available in IV solution in the United States, but I don't know if it will be available in India, aside from orally. Tablets and syrup. So no IV. But I will say, as I mentioned, that it's well absorbed across the oral mucosa compared to other opioids like morphine. So we do use that sometimes in patients who can't swallow other formulations well. So I had it. So the syrup's going to be 5 milligrams per milliliter, it says in the chat. So I have a question. Yeah, how do we differentiate between T half-life 25 hours and half-life of 50 hours on day 7? You can't look at an individual patient and know exactly how they're going to clear the methadone. So that's why we dose conservatively, and we monitor the patient. Oftentimes, because we do dose conservatively, we might need to increase the dose later. But one thing that we can keep in mind, we know that patients with cirrhosis will clear methadone more slowly, and older patients often will clear methadone more slowly. So those patients, we can expect that we may need to wait more days before we increase the methadone dose. I also had a question of what about the dependency factor? So dependency is when our body gets used to a medication and we can't stop it right away, or we would have withdrawal. And our body gets dependent even to blood pressure medications. So just like other opioids, patients will develop dependency to methadone, just like they do with morphine. And we don't want to stop it right away. However, because of its long half-life, sometimes it is easier to taper and stop methadone compared to things like morphine because it stays in the body and sort of slowly exits. So they don't have the withdrawal symptoms as severely. If a patient has toxicity to methadone, though, then you would stop it without tapering, depending on how severe the toxicity is. So if you work in an environment and you got an EKG and someone had a prolonged QT greater than 500, you would stop the methadone, wouldn't slowly taper it. And then you would just manage the patient's symptoms. But otherwise, we do taper it because dependence will develop. Any other questions? For toxicity, is there any drug to reverse effects, like naloxone for morphine? Yes, you can use naloxone to reverse the effects of methadone because methadone's long half-life and that it's in our fat tissues and in our body tissues and has to slowly release out. Naloxone only lasts 30 minutes. So one dose is not going to be enough. In fact, in the United States, if we need to reverse methadone because of respiratory depression, we do have to usually use a naloxone drip, so an intravenous drip. They would need multiple doses otherwise. There is the question about opioid-induced hyperalgesia. I must have missed that one. Let me see. So opioid-induced hyperalgesia, can I elaborate on it? Yes. So opioid-induced hyperalgesia is a pretty controversial clinical topic. Some people think that it's tolerance, amplified, but what we look for opioid-induced hyperalgesia to things like morphine is if we increase the dose of morphine in an amount that we think would make the patient's pain better, give some pain relief, and they have more pain, that's a worrisome sign that opioid-induced hyperalgesia is developing. If they had pain in one location of their body before we started treating and increasing the opioid doses, and then the pain spread all over into other areas and was more diffuse, that's a sign that they may have opioid-induced hyperalgesia. If a patient developed myoclonus from opioids, that's another sign that they're developing opioid-induced hyperalgesia and toxicity, and we would need to think about methadone might help in those cases.
Is it because of the glucose 6 glucuronide, morphine 6 glucuronide metabolite?
Of morphine? Yes, because of the the 6 glucuronide of morphine and the 3 glucuronide of morphine can build up in renal failure. And those metabolites are also thought to contribute to opioid-induced hyperalgesia, but it's not just morphine that can cause opioid-induced hyperalgesia. We see it with other opioids as well. Other questions? What is the most common side effect and toxicity that I've seen? So the most common thing that I've seen is constipation and sedation. When you first start the dose, people can get tired. Also, patients who are undergoing cancer treatments, sometimes here we start methadone because it has good data, for example, in head and neck cancer. And so we'll start methadone and then they're getting radiation treatment, and the radiation is going to make their pain better. And so they may be on a methadone dose that was working pretty well, but now all of a sudden they're getting sleepy with it. And so we need to decrease the dose. And I think this is because when a patient is in pain and you first start methadone, their sympathetic drive is pretty high. But when you have other therapies like radiation that's making their pain better, and all of a sudden their overall pain is lower, the same dose of methadone could make them sedated and cause toxicity, and so we need to decrease it. But constipation and sedation are the things I most commonly see. So OIH mainly caused by N3G and not by N6G. N6G is pharmacologically analgesic. Well, I would say that it's not just morphine that can cause opioid-induced hyperalgesia. So it's not just those metabolites that can cause opioid-induced hyperalgesia. But again, that is a controversial topic. I've seen some pretty heated debates about it at meetings. Absolute contraindications. Congenital long QT syndrome. And I also would not use it in a patient who has a family history of sudden death that is likely sudden cardiac death. Anything else?
Can I ask you a question?
Yes.
Yeah, hi. I'm more used to prescribing methadone for de-addiction therapy. But my question is, when patients, can you hear me?
Yes.
Yeah, my question is, how are patients on de-addiction therapy?
I'm sorry, you're breaking up.
But then when it comes to palliative care,
Rajit, your voice was breaking. Could you please repeat?
Can you hear me now?
Yes, yes.
Yeah, Andrea, I wanted to know, can you help this more towards prescribing for? My question is, how come patients on de-addiction therapy are good with once daily dosing, while patients with pain management, they need at least thrice or 4 daily dosing? Why is that?
So breaking up a little bit, but I think you asked, why do patients who are on methadone for maintenance therapy, so maybe they are on methadone because of a previous addiction to opioids? Is that what you were saying? They need once daily dosing, but then for pain, they need 3 times a day dosing?
Yes, that was the question. Yeah.
Okay. All right. So we do typically see that. I think you have to remember that the analgesic effect of methadone for many patients only lasts 6 to 8 hours, and 8 hours typically. And so the methadone stays around even after that, but it's not providing analgesia. And when we're using it for opioid substitution therapy, the purpose is to keep the patient out of withdrawal. And so that's why the once a day works for them. Once a day keeps you out of withdrawal, but it does not control pain. So again, because the analgesic effect is shorter than some of the other effects of methadone. I would say that we do see patients who do get good pain control even on every 12-hour, and sometimes, as I mentioned, in our very old and frail patients, once a day dosing of methadone, and that's probably because of the way their body's clearing the drug. But it's a little bit of a conundrum that we don't have great explanation for in terms of why some patients get good pain control on every 12 hours or every 24, whereas most require every 8. Should we check electrolytes periodically for those on methadone? Well, I think you have to balance the patient's goals and the likelihood that they would have electrolyte abnormalities. I think that getting lab draws is unpleasant for patients. So typically, if I have access when I'm taking care of a patient who's at home for comfort care only, if I have access to their labs, I'll look at it, but I don't order new labs. I look at other medications they might be on. So if they were on Lasix, a diuretic, that could lower their potassium level, then I would more want regular labs to feel more comfortable using methadone. So what are the prerequisite questions and investigations prior to initiating methadone? So I would ask, has anyone ever diagnosed you with a heart disease, a congenital heart disease? And then I would also ask what other medications they're taking. So those are the two big ones that I want to know. Again, if they're a patient at high risk for having abnormal potassium or magnesium, then I would check a lab. But for most patients, you have to weigh the patient's goals and the risks and benefits and harms of getting that lab for them. Should we be excited about methadone for pain management? So this was my first time visiting Pallium and spending time with Pallium this past year. And I am so excited that you guys are going to have this wonderful medication for your patients. I saw some patients who were so uncomfortable, and we were all doing everything we could to get them comfortable, using all the tools we had, giving them morphine as often as we could, and not able to control their pain and get them as comfortable as we wanted. And now we're going to have this wonderful tool to allow them to sleep through the night free from their pain, for example, and to be with their families. And I'm so happy that this is happening, and I hope you all are too. Methadone is a really interesting drug, and I would say that as long as you know what to look for and you monitor your patients and you are careful with your dosing, it's going to be a wonderful experience for all of you, and you're going to love seeing the impact that it has in relieving suffering for your patients. How did Pallium obtain methadone? What is the story? From where is methadone absorbed? So it's absorbed orally. It does use the P-glycoprotein in its absorptive pathway. So there are some drug interactions there that we didn't talk about today, verapamil being the most common one to think about. So it can interfere with its absorption a little bit. But there's a lot we still don't know about P-glycoprotein and methadone, so a lot of research there. How did Pallium obtain methadone? And I think Pallium said, you're waiting for methadone, so you don't have it yet, but we're waiting for the government order. Okay.
Gayatri, you can give a brief about how you got the medicine, or Naveen, one of you, because you already have it.
Hello. Yeah, we got methadone in Hyderabad, and we went to the normal process, the same process by which we apply for morphine. So from the hospital, the same process. The application goes to a drug controller and get the sanction for the amount which we asked for, and then we pay the order. The same process.
Thank you, Gayatri. Methadone is in the same list of notified medications which are, going through the drug controller, single agency, same rules, same as morphine. So only thing, the company that produces is only one in India, and so you will get the supply from there. Otherwise, the process is the same. You just have to add this name into your application to the drug controller.
Nandini, can I ask one more question?
I think it's, if everybody is okay with a few more minutes, it's absolutely fine. We had promised 8:15, and I think it has, but definitely we want to hear. Please go ahead. And at the end of it, I would like Gayatri, Naveen, and Dr. Ann to say a few things about this topic, because all of you all are available and your experience could be shared. So at the end of this question, this would be the last, and please, the faculty here, share something on this topic for India.
My question is, Nandini, since we don't have injectable methadone, what if this patient, we initiate them on methadone, they become moribund, and the patient is not able to swallow the methadone? Then what do we do then?
Kashelle, did you hear the question?
Yes. So if the patient is started on methadone and then they can't swallow, what do you do then?
No, patient is in the terminal phase, moribund, and unable to take things orally, and we have only tablets and syrup. We don't have injections.
Right. So your syrup is a little less concentrated than the options we have right now. But I would use the most concentrated oral syrup you could, and then you can put a small volume in the cheek and let it absorb across the cheek. Some of it will drip down, but typically at that stage for those kinds of patients, this would work if they're not on a really high dose of methadone.
You mentioned 30% absorption?
Yes, 30%. Across the oral mucosa, so across the cheek. So that's what we typically do here in the United States when that happens. We do have more concentrated, and so I think we could think about and look into whether or not we would be able to compound something more concentrated for those kinds of patients.
Dr. Ann, you wanted to add on to this answer?
Thank you. I just had a patient exactly like this, and it worked perfectly to do the syrup, and she maintained better control. We had initially changed her to a morphine intravenous solution, and it was not successful. Went back to the sublingual or cheek deposition of the syrup, and it was brilliant. So just reassure people that they could continue to use the syrup.
Thank you.
Naveen, would you like to make any statement on this topic on pharmacology and relevance to India?
Hello. I think Kashelle has covered most of the things actually. So especially with regards to the ECG monitoring, there are certain recommendations. I don't know how stringently we will be able to follow. Like at the baseline and after 2 weeks, after 1 month, for especially oral methadone. And if it's a parenteral methadone, the recommendations are very different. So if it is the patient is an inpatient or patient is followed up regularly on an OPD basis, it's feasible. But in a hospice setting, I think it would be very different.
I agree with that, Naveen. We typically will get EKGs before we start methadone if the patient's in the hospital or coming routinely to the hospital and clinic. But in the hospice setting here in the United States, if patients are at home with comfort care, we do not.
Yeah.
Anything else, Naveen? That was very...
Yeah, I think you covered most of the thing. I think you covered the metabolism, and I think with regards to methadone, I think certain things we are going to discuss next time about rotating and reverse rotating. We can talk more about that part in the next session, next eco session.
Gayatri, someone has asked about the cost of methadone in India. Could you just tell them approximately?
I don't remember exactly. It comes as 150 ml syrup. One bottle is 150 ml, and each ml is 5 milligram. And when we calculate the equivalent dose is coming less than 1 rupee. So when you calculate 5 milligram, it's less than 1 rupee. So it's very cheap. I don't know the exact cost. Maybe next time I'll just come with the exact cost.
That means 10 milligrams for less than 1 rupee. Is that right?
5 milligram.
5 milligrams for less than 1 rupee.
So 60 paisa like that. So it's yeah, we realized that it was cheaper than morphine. I don't remember the exact. Probably Jean may remember, or Naveen.
I think it is if the patient is taking an equivalent dose of 60 milligram morphine per day, then the dosing, the cost is around 15 rupees per day. A 60 milligram equivalent morphine per 24 hours. The cost, if it's methadone, it comes to 15 rupees per day. That's how we calculated the pharmacoeconomics of all the opioids. So we kept a 10 milligrams fourth hourly. So that's equivalent to 60 milligram morphine equivalent per 24 hours. And the cost comes to 15 rupees if it's methadone.
I guess we need to close the session. We have 3 more coming up, and we will be having more clinical discussions during those 3. We thank Kashelle from the bottom of our hearts. Thank you so much for being available. It must be very odd hour in your country, and it must be early morning, right? So
it's morning. It's not too early.
Okay.
Thank you.
Thank you for your valuable time.
Thank you, everyone.
Yeah, and thanks to all the centers which have joined for this meeting. Please stay on for the remaining 3 because we are doing this differently at this time because of the international faculty, and we will be moving on to other parts of this program, and that will be during regular office hours. So just for these 4, please bear with us during these late hours. I'm sure it must be dinner time at your house. Thank you for your time, and please keep your questions, and we will come out with more questions during the future sessions. Thank you so much. We'll be sharing the presentation and some of the points that came up during the discussion by tomorrow morning.
And some references. I'm going to share some papers of interest.
That will be great. And the next topic, it would be very nice if you could share some pre-class topic, articles to read, and so that we can come a little more prepared for each session. So I request the faculty to share some reading material to the group, and we can go through that and be better listeners during the class. Thank you.
Thank you.
Thank you, everyone.
Our next session is on 15th, 7:15 p.m. I request all of you to please join for the next session. It is by Dr. Suresh Reddy.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.